Okay, so let's start with this session. Can we have Dr. Vivek, please? Dr. Vivek will be talking about incidence and risk factors of retinal detachment following silicone oil removal post-vitrectomy.
Good afternoon, everyone. My topic is about incidence and risk factors for retinal redetachment following silicone oil removal. Silicone oil is first of all used by CBS et al. For as an endo-tamponade in the complicated retinal detachments.
Just a minute.
Good morning, everyone. Sorry for holding back the program. We were in a confusion who should be judging the thing, so we have now reached a consensus. Dr. Renu and Rituraj would be judging, as well as we have a senior faculty, so we can request sir to be faculty. Sir, please, why don't you join us on the desk? As I am supposed to leave at in another half an hour for OPL, so can I request you for that honor, sir, please? Please, sir. So now, I'm sorry, better, please go ahead.
So silicone oil, variety of complications such as secondary opening glaucoma, corneal endothelial decompensation and cataract. One of the dreaded complications of silicone oil removal, post-removal, is about retinal redetachment. Our aim of the study is to determine the incidence and risk factors for retinal redetachment following silicone oil removal in eyes, especially with rhegmatogenous retinal detachment post-vitrectomy. It is a retrospective study conducted over a period of 27 months, and the following parameters like demographic, preoperative and the best corrected vision after 3 months, and intraocular pressure baseline and 3 months, extent of the detachment, duration of the tamponade, and the duration of the symptoms which the patients had, like flashes, floaters, were noted. The lens status and the presence of proliferative vitreo retinopathy were also noted. Eyes with rhegmatogenous retinal detachment who had at least a follow-up period of at least 3 months were included, and all other retinal detachments with coexisting retinal pathology such as diabetic retinopathy, hypertensive retinopathy were excluded from the study, and the patient who received tamponades like gas, like silicone perfluorocarbon liquids, were excluded from the study. So initially the patients had undergone a 23 gauge pars plana vitrectomy for the rhegmatogenous RD. Genetic tears were located and the clock hours of retinal detachment were noted. Adequate vitreous shaving was ensured and the laser was given around the retinal breaks, and silicone oil was injected and subsequently removed after 3 minutes. So about a total of 115 eyes were included in this study. 103 eyes had a single surgery attached retina, and the number of eyes which had redetachment were 12, and the incidence is about 10.43%. Here the duration of the tamponade can be comparable to both single surgery attached retina and as well as redetached eyes. The mean age group was about similar in both redetached group and as well as in the single surgery attached retina group. 4 eyes had superior located RDs and 2 eyes had inferior located RDs. No encircling bands or any other additional procedures were done, especially in the cases of inferior RDs, and 6 cases had total RDs. Only 1 case had less than 3 clock hours, and about 11 cases had more than 3 clock hours in the redetached group. Among the redetached group, 3 cases had cataract and 8 cases were pseudophakic and 1 were aphakic. The IOP was within the normal range. The vision was not recovering in the case of redetached group. Only two eyes, that is 16% of the cases had redetached group had the PVR changes. Among the redetached group, it was having complications such as persisting macular hole and uveitis, and further recurrent RD was seen in the case of redetached group, and peripheral anterior NK was seen in 1 case. So coming to limitations of my studies, is a small sample size. and it had a very shorter follow-up. So after performing multiple linear regression tests with the above said factors, we concluded that the lens status is statistically significant predictor of the recurrent retinal detachment. These are my references. Thank you.
Was phacoemulsification done at the time of
No, sir.
because phacoemulsification is one of the
It is a single surgery.
was any membrane peeling done at the time of oil removal?
No, nothing was done, sir.
And particularly how did you manage to equalize the PVR what was the grade of PVR?
Only 2 cases had, and one of them were having grade. One of them was having grade C.
And the rest of them were grade B and
Rest of them were below the grade C, sir.
right. And what particular reason was there such less PVR cases?
No, I can't get you.
If the PVR grade usually usually we use silicone oil for higher grades,
Yes, sir.
So any particular reason why the oil was used for lower grades of PVR?
No, I can get it, sir.
The question is, in the primary surgery, why did you use silicone oil? What was the indication? Because usually if the grade of PVR is more than PVR-C, then you need to do a silicone oil injection. That's what Dr. Vitreo is asking.
Okay, I can
Can
get
you give him an explanation? No, you don't use gas as a routine tamponade. Oil is your preferred tamponade in all cases of detachment.
when it is more than when it is having giant retinal tears or the break is very large, we can go for PFCL for otherwise we will prefer silicone oil, sir.
Not understood. Okay, next.
Thank you.
Thank you. Next, may I call Dr. Sandeep Kumar? Last meeting. Dr. Sandeep Kumar.
A very good afternoon to you all. I'm Dr. Sandeep Kumar from Shroff Eye Center, and we will be discussing our project on Densron Extra for recurrent retinal detachment. No financial disclosures. So, since its introduction in 1960, silicone oil has been effective internal tamponade in treating RD. The success rate with superior RD has been around 95 to 100%, but when it comes down to inferior detachment, the success rate falls to around 80, and when it is combined, it is accompanied by PVR, then it can be as low as 30%. Inferior RD with PVR have always been a challenge for VR surgeons because of the inadequate inferior tamponade associated with lighter than water tamponades like silicone oil that leads to inefficient cover of the inferior retina, leads to formation of PVR soup, and it is more pronounced when there is subtotal filling. So to counter all this thing, heavier than water silicone oil tamponades were introduced. The earliest heavy tamponades tried were fluorinated silicone oil. They received a major backlash with the heavy PVR changes, emulsification, inflammation, and raised IOP. So they were withdrawn. Then in the early 21st century, new heavier than silicone oils were introduced. They were a combination of semi-fluorinated alkanes or alkenes and high viscosity silicone oils. They promised and delivered adequate tamponade, lesser inflammation, and others related complications that were mentioned in the literature. Now, Densron Extra is a relatively new addition to the silicone oil group. It's a colorless, homogeneous liquid composed of ultra-pure silicone extra and F6H8. The heavy silicone oils, they have faced criticism for their complication rates, especially the raised IOP, inflammation, and in situ emulsification. Densron 68 in particular has found to be associated with inflammatory reactions in the anterior chamber, sometimes leading to fibrinous membrane formation. Whereas Densron Extra, the chemical composition of the extra helps minimize the risk of silicone oil emulsification. It has got a thixotropic behavior, and the main component, the additive component, is Siluron Extra, which leads to lower emulsification rates, higher resistance to emulsification, and a lesser injection time when compared to Siluron 5000, which is used in Densron 68. Now, this is a table describing the 68 versus Extra, which shows Siluron Extra is the main component in Extra and Siluron 5000 in 68, and it has got 68 has got more viscosity and more emulsification rate than the Extra thing. So when we looked up, there was no study in the literature evaluating the safety and efficacy of Densron Extra as a heavier than water tamponading agent. Our study objectives were to analyze the effectiveness of Densron Extra heavy silicone oil in managing recurrent retinal detachment, evaluate anatomical and functional outcomes and complication associated with Densron Extra, and compare with existing HSOs, especially Densron 68. The study was conducted at Shroff Eye Center, and 19 eyes of recurrent retinal detachment were enrolled. The study design was retrospective, non-comparative interventional study, and they were followed up for 6 months post-Densron Extra removal. Routine revitrectomy was performed for all the patients. 2 eyes with redetachments with Densron in situ underwent revitrectomy with membrane peeling, and in them the Densron was removed and replaced with silicone oil 5500. After the initial post-op period, the patients were followed up 1, 3 and 6 months. The BCVA was recorded at the end of 3 and 6 months. 6 months following Densron removal, the final visual acuity was taken. Patients were also evaluated for any complications. The success rate was defined as stable attachment 6 months after Densron Extra, and secondary success was defined as stable attached retina after 5500 oil removed without further intervention and no PVR changes. Okay, so 18 of the 19 eyes that we involved had inferior break. 1 patient had both inferior and superior break. All 19 eyes were of macula of redetachments. The patient with superior break had a total RD, whereas 18 other had inferior RD. Subretinal bands were seen in 8 out of 19 eyes. The visual recovery was statistically significant. Anatomical success was achieved in 89.4% of cases. Redetachment Densron Extra in situ was noted in 2 out of 19 eyes. These 2 patients had anterior PVR changes and circumferential bands. The mean time of Densron removal was around 5 months, and following second surgery, there was a 100% attachment rate at the conclusion. Now, PCO, cataract formation, and increased IOP were the 3 most common complications that we encountered. 2 eyes reported post-operative inflammation. Topical steroids were used to control them, and they got easily controlled. Densron emulsification was reported in 1 eye. 1 eye with post-trauma retinal detachment reported hyphema of grade 1 in the post-op period. Ocular hypertrophy was not reported in any eye. 1 eye reported ERM formation that didn't require any intervention. There was no case of endophthalmitis. These complication results were either comparable or lesser than D68 that have been reported in literature. Retrospective nature of the study, lack of randomization, and smaller number of patients are the limitation of our study. So to conclude, Densron Extra with its lower viscosity than Densron 68 allows easy injection and removal. Densron Extra is associated with a lower incidence of emulsification, inflammation, and glaucoma than 68 and other HOs. Our study results support the relatively inert and non-inflammatory nature of Densron Extra, and it is expected that the result of our study will be groundwork for future studies with Densron Extra. Thank you. Thank you, sir.
I need to comment on that. So the message which should go is not particularly, what kind of Densron you are particularly using, but in cases of redetachment.
Inferior, especially in the PRG.
What you need to do is more of meticulous vitreous-based shaving and getting the vitreous base out. Getting the vitreous base out and doing meticulous vitreous-based shaving rather than the particular choice of temporal. I would like to ask you regarding the membrane formation. In which area did you see the membrane? Because
the redetachment cases.
No, there was some membrane thing which you had mentioned.
There are 2 cases. That was about the patient, those who have redetachment. They have anterior bands, loops, and circumferential bands in which they got Densron C2 and redetachment. There were those 2 cases.
All right.
Yeah. So we did a retinectomy and then took out extra. And
with Densron, it's in the superior area, where these kind of membranes and these kind of PVRs form, because of course
yes, sir. Either it can be. We try to keep the filling. But if there is any suboptimal filling or there is any missed break or something, then it can lead to a gap in between retina and the extra phase. That can lead to those formation of membrane. That is the concept behind PVR soup.
I think as a competitive paper, whenever you are presenting, you should not identify your institutes as well as the,
Sure.
you should never have your hospital as well as the last one.
Okay,
That goes against the protocols of
Okay,
ethics.
Thank you, sir.
A very good afternoon to everyone.
I'll be presenting my paper on trials and tribulations of pneumatic retinopexy, where I'll be discussing about the incidence and outcome of perioperative and post-operative complications. We all know that pneumatic retinopexy is a non-invasive and minimal procedure which is used for primarily uncomplicated retinal detachments with minimal PVR. Single operation success rate in various studies has been shown to be around 45 to 80%. The functional outcomes, however, of these eyes repaired successfully, these exceed those of scleral buckling and pars plana vitrectomy in many cases. This study was planned to report on the anatomical and functional outcomes in uncomplicated retinal detachments of pneumatic retinopexy, as well as report on the perioperative and post-operative complications as well as their management. So this was a prospective observational case series study where patients undergoing pneumatic retinopexy were enrolled in the study. Any patients which were younger than 18 years or any pre-existing conditions that would preclude them from maintaining the desired posture were prohibited from the study, as well as significant PVR-C was also an exclusion criteria. The pneumatic retinopexy was performed within 24 hours of the presentation of the patient, and using the protocol that is described in the pivot trial. All the patients were instructed to perform initial face down posturing, and macula on cases they were instructed for 4 hours prone positioning as well as 6 to 8 hours in macula off cases, and which was followed by the steam roller maneuver. Patients which completed a minimum follow-up period of 3 months were enrolled. This is the basic demographic details of the patients. The mean age was around 50. 18 of the we enrolled a total of 27 eyes of 27 patients. 18 of these eyes were macula off and 9 were macula on. 18 eyes were phakic and 9 were pseudophakic. Almost 37% of our cases were two quadrant, like half of the retina was detached, and 6 each eyes of 3 and 4 quadrants were involved. Mostly we preferred SF6 as a tamponade agent. Only in few cases C3F8 was used, and whenever possible we applied both cryopexy as well as laser retinopexy, but in certain cases where we could not, then laser retinopexy was the preferred modality. So retinal attachment was achieved with single pneumatic retinopexy in 21 of the 27 eyes. One of the eyes underwent a second retinopexy procedure, so that the success rate was 81.4%. 5 of the eyes had to undergo pars plana vitrectomy with gas or oil tamponade. The reattachment rate with the second procedure was 100%. So this is the improvement in the logMAR best corrected visual acuity that we saw from pre-op to 1 week and 3 months post-op. So now I'll briefly discuss the complications that we encountered. Fish eggs of the injected gas was the most common complication, which was encountered in 5 of the 27 eyes. The main problem is that this will preclude the laser therapy to the break area. However, it can be forced to coalesce using the forceful tactile stimulus, but in almost all the eyes we saw that within 24 to 48 hours the bubble coalesced on your own, and there was no correlation with final success rate or visual acuity. Another complication was noted in pseudophakic eyes as well as high myope eye. One eye was a pathological myope with weak zonules. There was gas in the anterior chamber. This was managed out by expressing the gas and forming the anterior chamber with Helon and re-injecting into the gas bubble in the vitreous cavity up to the desired volume. One of the patients also suffered from a cryoburn, which was due to an inadvertent injury due to the sleeveless cryoprobe. But this was managed with topical clobetasol and silicone gel, and the patient had minimal scarring. Subretinal gas was noted in one of the eyes, which had a large superior retinal dialysis of more than 2 clock hours. This was managed with supine positioning and expressing out the gas using a scleral depressor, following which the laser therapy was possible to the break area. Vitreous hemorrhage was also noted in one of the eyes, and this precluded laser therapy. However, we'll be able to mostly laser through the bubble. As you can see in this case, the media is hazy, but after a while you can laser through the bubble. Choroidal detachment was noted in one of the eyes. This was a pathological myope. This patient suffered from choroidal detachment. Initially the retina was attached, but she suffered from a redetachment a month later, which had to be managed with pars plana vitrectomy, during which we found that there was vitreous traction along the superior area. Post-operative complications, we saw that there was persisting subretinal fluid, which was noted in 3 eyes. This patient presented with a macula on RD, and after injection of the gas ball, we see that there is a fluid collection inferiorly. And we saw that there was also formation of a lamellar macular hole in this patient with inferior subretinal fluid which was persisting, but this was not associated with significant worsening of the vision. This is another case which had persisting subretinal fluid, but there were no outer retinal corrugations, and the patient had a vision of 660, and we are following up this patient. This was a patient which had a temporal break, and this was managed with pneumatic retinopexy, and we see there's a small neurosensory detachment at the foveal region. This patient had a vision of 612. We also saw that 33% of eyes with macula off RDs complained of micropsia or metamorphopsia compared to only 2 eyes in the macula on group. The redetachment was seen in 6 eyes, where we saw that the most common reason was that the break was below the horizontal meridian, which was an adventurous decision on our part to undertake pneumatic retinopexy. In most of the cases, others we saw the persistent traction on the break side, and there was a missed break as well as creation of a new break. This is one of the patients that had a failed pneumatic retinopexy. You can see a large horizontal tear. Initially there was attachment, but the patient suffered from a redetachment, which had to be taken up for pars plana vitrectomy. This was another of patients where we see that though we were able to laser the superior area, but inferiorly the fluid was subsistent, significantly persisting, and the patient had to be taken up for a pars plana vitrectomy. This is a remarkable case that the patient had a Strassmann syndrome with myelinated nerve fibers, and he presented with 360 degree of choroidal detachment as well as retinal detachment, and we see a supratemporal break in this area. And this patient, we were able to inject almost 1.5 cc of SF6, and the patient had a retinal detachment. However, the vision did not improve more than finger counting. So we conclude that it is an indispensable tool for a VR surgeon. The complications are frequent, but they can be tackled effectively with little bearing on the final outcome, and anisoconia is mainly related to the preoperative macular status. Thank you.
Thank you.
Did you encounter any case of raised intraocular?
Post-op day 1, none of the cases that are persistent managed medically. Most of the patients I saw, they had post-op elevated IOP mostly till day 2 or 3, but after 1 week there was like normalization of the IOP. None of the patients had significant, none of the patients needed any anti-glaucoma drops more than like 1 or 2 weeks. After that we were able to normalize the IOP, because that is the time that we look for.
What's remarkable was that the subretinal gas, you were able to manage it without a second procedure.
Yeah.
Thank you. Dr. Soumya is there?
Thank you.
Oni, क्या नाम है? हैं? अपूर्वा आ जाओ.
Good afternoon all. Today my topic is on case of through the optic disc pit, a case report of maculopathy unraveled. Chief author is Dr. Soumya, presenting author myself Dr. Apurva, co-authors Dr. Darshan, Dr. Pooja and Dr. Bindu Malini. Optic disc pit is a rare congenital anomaly of optic nerve head. Optic disc pits are thought to occur in approximately 1 per 10,000 patients without any gender or racial predilection. Although they are typically unilateral, bilateral presentation has also been recorded in around 15% of cases. Majority of cases are sporadic. Autosomal inheritance has also been seen to affect many members. Here now I present one such case of a 42-year-old female patient who presented to our OPD with a diminution of vision for distant and near in her right eye since 3 months. Her history of presenting illness was a gradual diminution of vision in her right eye, which was painless in nature. She also complained of transiently seeing a dark spot in the center of her visual field. She had no history of headache, no history of metamorphopsia, or no history of any color desaturation. In past history, she gave no history of any similar complaints in the past, no history of any drug intake, no any systemic comorbidities or any other significant history. On examination, the systemic examination turned out to be normal. On ocular examination, in the right eye, our best corrected visual acuity was 6/18 in Snellen's. In the left eye, it was 6/9. The near vision was N36 and N6 in the left eye. In the anterior segment evaluation in slit lamp biomicroscopy revealed a right eye. It was normal with a pupil of 3 mm size, round, regular and reactive. Same as the left eye, the anterior segment evaluation was normal with the pupil of 3 mm, round, regular and reactive. And she was subjected to fundus examination. In the right eye, it showed a grayish oval shaped depression temporally at the optic disc with the thickening of the retina extending along the papillomacular bundle and with the arcuate bundles up to the macula with the macular bundle. This is the posterior pole showing in the optic disc showing a temporal demarcation depression with the thickening of the retinal layers in the papillomacular bundle and arcuate with the macular edema. Whereas the left eye fundus examination, the disc was normal with a CDR of around 0.4 and the disc margins were clear and macula was normal with a good foveal reflex. And she was subjected to visual field analysis with HFA central 30-2, whereas in the right eye it showed less sensitivity in the centrally in the probability plot of a total and pattern deviation, suggesting a macular involvement. The left eye visual fields were within normal limits. The SDOCT macular cube, the right eye showed a subfoveal serous retinal detachment with inner retinal schisis and a fluid-filled spaces with a spongy thickening of the outer retinal layers nasally extending up to the optic disc. Her central foveal thickness of the right eye was 839 micrometers, whereas the left eye there was a normal foveal counter with a central foveal thickness of 220 micrometers and the OCT of the left eye were within normal limits. So with all the above examination and the history, she was diagnosed to have a right eye optic disc pit maculopathy. Optic disc pit is a congenital anomaly believed to be secondary to a disturbance in development of the primitive epithelial papillae, but the exact causes still remains unclear. It belongs to spectrum of congenital cavity anomalies of the optic disc, which encompasses extrapapillary cavitation, optic disc coloboma and morning glory disc anomaly. Optic disc pit can be associated with maculopathy leading to progressive visual deterioration. Despite advances in imaging, the exact origin of the fluid at macula remains unknown, although some cases have been reported to resolve spontaneously. Most cases require a surgical intervention. So optic disc pit is typically usually an incidental finding. Rarely it may cause a visual field defects and macular involvement leading to optic disc pit maculopathy. So in such cases of any macular edema like CSR, optic disc has to be examined thoroughly to rule out an optic disc pit associated maculopathy. Also in patients presenting with central scotoma or diagnosed to have optic disc pit, macular involvement should be considered for diagnosis and prompt management. Overall, the vas plana vitrectomy with ILM peeling remains the main form of surgical repair for optic disc pit maculopathy. These are my references. Thank you.
Common
Sir, around 15% of the cases.
the cases? Okay, anyone?
No, I was just saying, you just written the mainstay of treatment was just PPV. ILM peeling is also...
There are various methods which I will do.
PPV with ILM peeling.
Nowadays, they have also tried to plug in.
Plugging of the scleral
Yeah,
plug and
those
ILM peel
scleral
has been
plug,
various types. Routinely,
Tenants as well.
because certain percent of the cases vitreous is there for traction. So in those vitrectomy, people have used. People have used. Okay, people have used. Dr. Sweta, come next. Thank you. अभी लास्ट में बता देंगे डॉक्टर साहब डॉक्टर मेरा है ना नॉन कम्प्लीट प्रैक्टिस के लिए
Good afternoon everyone. I'll be presenting on brolucizumab in pachychoroid disease. Sorry, my slides are not moving forward.
स्लाइड देखो
So what is pachychoroid? It is a disorder of choroidal vasculature. The key defining features include choroidal hyperpermeability, which is detected on ICGA, with inner choroidal attenuation. It is the presence of dilated halo vessels, which are the pachy vessels, which make this disorder characteristic. There is focal increase in choroidal thickness. So it is not just one disease, but rather a spectrum. With improved retinochoroidal imaging, this has led to better understanding of this disease and help them differentiate them with other retinochoroidal diseases also. So progression from one disorder to another is frequently observed. So the spectrum includes central serous chorioretinopathy, pachychoroid pigment epithelopathy, polypoidal choroidal vasculopathy, peripapillary pachychoroid syndrome, and focal choroidal excavation. So about brolucizumab, it is the anti-VEGF with the lowest molecular weight with higher molar concentration. It has the potential to effectively penetrate the choroidal and retinal vasculature, which positively impacts its durability. Now with the non-availability of verteporfin dye and decreasing PDT, there is a need for some therapeutic measure to target the choroid. And here comes the rationale of using brolucizumab in pachychoroid disorder. So we did a study to evaluate the efficacy and safety of intravitreal injection of brolucizumab used as Pagenex in India in previously treated patients of pachychoroid syndrome with PRN regimen. Primary objective was to assess the functional improvement, and secondary was to assess the anatomical improvement in terms of central subfield thickness. We also measured the changes in PED height or resolution of sub or intraretinal fluid, and occurrence of any ocular or systemic events were also noted. So this was a single center retrospective analysis. We took the records from Jan 2021 to July 2024, and we included the patients who were given PRN regimen of Pagenex for CSCR, PNV and PCV. We excluded those who had received anti-VEGF agents within 2 months, any intraocular surgery within 3 months, and patients with hazy media which obscured imaging. So out of 161 eyes of 141 patients who received Pagenex on PRN regimen, 23 eyes of 19 patients who had received 66 injections met the criteria. And we recorded best corrective visual acuity, central subfield thickness, and changes in PED height. The patients were categorized based on the follow-up of 3 months, 6 months, 12 months, and 24 months. Now, 11 patients with a follow-up of 3 months, mean injection ranging 1 to 2, showed significant improvement in best corrective visual acuity along with improvement in central subfield thickness. 5 patients with follow-up of 6 months, they showed improvement in best corrective visual acuity and CST, but it was not significant, probably owing to the smaller sample size. Now 4 patients with 12 months of follow-up, they showed bit increase in logMAR BCVA, that is bit falling BCVA, but this was insignificant, but they showed significant improvement in the central subfield thickness. And 3 patients with 24 months of follow-up, mean injections ranging between 6 to 8, they showed unchanged BCVA with improvement in CST. So cumulative data of all the patients showed that they have shown stable BCVA, decrease in central subfield thickness, and decreasing PED height from baseline to final follow-up. So 9 out of 23 eyes, they showed improvement in BCVA, that is 39%. Stable BCVA was shown in 12 out of 23 eyes, that is 52%. 2 eyes demonstrated loss of 1 Snellen's line, that is 8.7%, probably owing to the natural course of the degenerative disease. 20 out of 23 eyes showed a reduction of CST, that is remarkable, 87%, and 14 out of 15 eyes showed a reduction in PED height, that is 93%. Also, no adverse events, specifically any incidence of IOI were recorded. So to conclude, PRN regimen of brolucizumab was effective in improving and maintaining visual acuity. It showed marked drying effect. Although Hawk and Harrier studies have showed reported IOI incidences of 4.6%, and VRSI study group has showed 0.79%, no patient developed IOI in this analysis, maybe due to smaller sample size, and that brolucizumab is effective in managing recalcitrant cases of pachychoroid disease spectrum. Limitations of the study is smaller sample size. It is a retrospective analysis. We haven't got any comparison group, so this limits the power of study, and larger studies are needed to validate these results. Thank you.
Any questions?
What particularly, when do we say that, is there a particular measurement for specifically telling that this patient is having a
pachychoroid disorder? So based on enhanced depth OCT, if it's 290 microns.
Is it 290
it is
or 390?
sorry sir. So basically it is a range and it is not just choroidal thickness. We have to look at the focal dilatation of Heller vessels which appear as large hyporeflective lesions beneath the RP. So even if its focal increase in choroidal thickness can be considered as a pachychoroid disease along with the other more characteristic features which include hyperpermeability on ICGA. So choroidal thickness, yes, so I must have forgotten the exact number, but it's more basically focal.
So I think that you could have tightened up your exclusion criteria by excluding cases with history of uveitis, or because as such brolucizumab is associated with IOI.
With IOI.
What do you think about that?
So basically when we were taking out the records, we
This
there
is
was
a retrospective
this is a
study.
retrospective analysis. We took out the records. None of the patients had any history of uveitis. Also, if it's a patient of uveitis, we avoid brolucizumab at all cost. We don't give.
ठीक है, Dr. Malika Goyal.
Thank you.
Second last speaker. Anybody?
I'll be speaking about my experience with fibrin glue for complex retinal detachments when silicone oil is also injected. This has not been described actually. At the time we started doing this, it was used only for some simple rhegmatogenous retinal detachments to avoid the use of oil and gas. But we have used it with oil for complex detachments. Okay. So as I said, it has been used earlier for simple detachments to avoid the use of oil or gas, but not reported for complex detachments with oil injection. So 2 years back we were faced with a situation, a PDR combined RD which did not settle because there was an open break superior to the macula. We attempted resurgery, tried to do membrane peeling around this hole and aspirated the SRF, but the hole did not close and so it was not amenable to laser. So we instilled some glue over the break and to our surprise the detachment very rapidly attached without the need for much of positioning. And this is the patient 2 years back who's still doing well. The oil is not emulsified. IOP was never high, no inflammation, retina stable. We removed the oil a few weeks back and the patient is doing well. This is a very recent patient. We have used for several cases. This one very recent, PDR combined RD after complete membrane peeling. At the end there was a break which was not amenable to laser as you see. We tried to do, it's not showing there, I'm sorry, the video is not running there.
Double click करो.
Okay, I'll try again.
Video देखिए.
Video is not playing.
Video.
It's playing on my computer. Okay, let's move on. So there was a break which was not amenable to laser. So if you see the white, that is the fibrin glue, that is where glue was instilled over the break. And you can see on day 1 retina was attached. And this glue resolved within a few days. And this was operated a few months back. Patient is doing very well. No complications from the glue. Another patient, again the video not running. This is a PDR. As we did extensive membrane peeling, there was a break superior to the macula, again not amenable to laser. So we injected 2 components of glue over the break, and you can see very rapidly the retina was attached, and you saw the pre-retinal picture was, pre-surgery picture was very bad. You saw the membranes, and you see now it was very good, and this is more than a year back. Patient is still doing very well, no complications. Again, the video not running, I'm sorry. Here the break was close to the macula after the membrane peeling. So again, we didn't want to do laser close to the macula. So fibrin glue was injected over the breaks, and that's bad. So this was showing, the video itself shows the post-operative course, which was very good. So we extended the indications to non-diabetic complex detachments. which included macular hole RDs, where you cannot do laser for the macular hole. And you can see in this patient, this was a thrice operated RD. There was no ILM because it had been removed. So we put glue over the hole, and very rapidly, 5th post-op day, the retina is nicely attached, macular hole is closed. And that was the glue. Again, young boy with an RD, macular hole was the only break, causative break. We did a drainage in a mid-peripheral location and then instilled glue over the macular hole. Again, the video is running on my computer, so that's okay. But if you see the 6th post-op day itself, you can see the glue closing the hole. On the 10th post-op day, the macular hole is closed, the retina is attached. And again, this is more than a year back, 1.5 years back. Patient is still doing well with oil in situ. Sometimes the hole may not close, but the macular hole RD will settle. And that itself is good because at least the patient regains most of the peripheral vision, like in this patient. And in this patient, 3 times operated for macular hole, failed. But in addition, he developed a retinal detachment. So we saw him at this stage. So during surgery, again the video not working there. During surgery, we attached the retina with and then put glue over the macular hole only. And you can see that the first post-op day itself, the retina is attached, the glue is closing the macular hole, and after some days, the hole is still open, but the retina is attached. And here you see subretinal glue, which is a very important thing to understand. This can cause some loss of visual function. So the tips for techniques is that the needle tip blockage is very common with this glue. So just before entering the eye, we must check that the needle is not blocked. Because if you go inside and try to open the block by forcing it, it enlarges the retinal break because it comes as a jet, and it also causes excessive injection. Now the glue, the 2 components of glue which are injected one by one are both transparent, and even when they mix together, they remain transparent for some time. So it's very common for us to go on injecting because we cannot see what we have injected. So we have to be vigilant to avoid excessive injection. I found that 2 cc syringes are better than 1 cc syringe because they are smaller, so easy to handle. And the blue one should be used first because it's more viscous. Subretinal glue is seen as you see here, and that can cause atrophy. So if it's a macular hole situation, we should be careful. There may be a loss of vision because of the submacular exudation. Even in peripheral breaks, excessive injection can cause the break to remain open, and there can be a failed RD, which we had to reoperate to attach the retina. So in summary, fibrin glue can be a very useful adjunct in the management of complex RDs where laser cannot be done due to bleeding, retinal edema, persistent SRF, or proximity of break to the center, or macular hole RD. It causes rapid retinal reattachment compared to silicone oil surgery alone, and the need for post-op positioning is reduced because now the break is closed on the table. We do not need silicone oil to positioning to close the break. And we have not seen any long-term adverse effects with silicone oil in situ. Thank you.
Thank you.
Is my time up?
Doctor, I believe, is it your meticulous removal of membranes working, or is it the glue which is working?
See, meticulous membrane removal is anyway required. Without that, even glue will fail because the break will remain open from the traction. So that has to be done, but when laser is not possible, then this is being used.
So the glue is causing a sterile.
No, it is actually physically, mechanically plugging it. It's like going and putting something to seal the break so that the SRF does not accumulate again, and the break is closed immediately.
More than anything, I would just like to learn from you. Ma'am, I just wanted to ask, do you decide on table that you will be using fibrin glue in this patient?
Yes.
Or is it like a pre-operative?
No, generally on the table when we fail with our laser, there has been bleeding or SRF is not going away, on the table, usually on the table.
Okay, and otherwise when you have these really bad detachments which have bands, subretinal bands, so is that, do you sort of have to remove the bands, or does it work with the bands, and will it just sort of physically stop it and put it down?
See, again, the criteria for removing bands will not change because of glue. You will still remove if you feel that the break is going to have a traction because of your bands, or the retina is going to be elevated because. So irrespective of glue or laser, you will still do your membrane removal or bands, subretinal bands removal as you would do in any other case. Then you take the decision for glue only when the break is not closing or your
Despite
laser is
all
not
your
possible. Laser or laser is not happening basically. I'm sorry, none of the videos ran. I'm very, very sorry, but
डॉक्टर साहब थोड़ा दिखला दो ये Good afternoon. I will be presenting the clinical profile and surgical outcome of optic disc pit associated maculopathy. This has already been described. This optic disc pit causes maculopathy and so causes decrease in vision. Prevalence is already given. 20 to 25%, 25 to 75% causes visually debilitating complication like maculopathy. And one of the important treatment is plasma vitrectomy with PVD induction is an effective option, but other option has been tried. So these are the various modality of treatment which has been there in optic disc maculopathy. So there are limited studies showing functional anatomic outcome following surgery for optic disc maculopathy. So we have studied the surgical outcome, anatomical surgical outcomes of PPV with various techniques. Primary object improvement is best corrective visual acuity. Secondary improvement anatomical outcomes of OCT. And inclusion criteria, these present optic maculopathy, visual acuity less than 618, patient willing for surgery, and patient willing for follow-up also. And these are the two we have divided into. One is PPV alone, the PVD induction is there, and another stuffing of the island, stuffing of the optic disc pit with various things. Like in the second group, stuffing optic with various material, interlimiting membrane, and two is scleral tissue. We have also used the glue but unsuccessful. This is the video of one of the case. क्या हो गया? वीडियो चलाना नहीं चलेगा ये कहाँ पे जाना देखना डबल क्लिक करना एक हाँ ओके ओके करना VLCP दूसरा डाउनलोड यहीं से डेस्कटॉप पे दूसरा initially PVD induction is done and vitrectomy is done, and after that this is the case where we have done this scleral plug. We have taken from the scleral tissue from the patient, and the thing is saved off, and it has been 1 to 2 millimeter, and in the forceps we have inserted, and we have put over the disc, and we just stuffed up optic disc pit with this scleral tissue. As you can see, initially we were very reluctant because it may cause optic nerve damage, but with successful using of other techniques we have tried to fill it this, because one of the important source of fluid is the optic bit from the CSF subretinal space. So as I have already told you, there are two methods: vitreous, the cause of maculopathy, vitreous factor, which can be relieved with plasma vitrectomy with PVD induction, and another is closure of the hole, because the hole is pit is the source of the thing. बंद करना कहाँ से होगा? Slide. So this is one of the case where there is a macular CSS. There is a in the all the layers in the NST. This patient has a vision of 612 and we have operated because patient was complaining of metamorphopsia, and after 1 year there is a resolution. This is a case where we have done only PPV with PVD induction only. So we have 10 cases. As you can see, visual acuity improve over the 1 month, 3 month, 6 month in the both the cases, and CMT reduction also been done. And SRF height is also decreased by initially 1 to 2 months, but it takes up to 1 year in the complete resolution of the SRF extent. So this is another case where we have done just observation. This just to show you if there is only maculocytosis, if there is no NSD, then we should not operate because there is no complaint. This is an incidental finding which was detected. This is another case where we have patient presented with 6 by 60 vision, and in this case we have put a scler grafting in the pit, and there is a resolution, not complete resolution. This is 2 months old. There is no complete resolution of the fluid still there, but there is a visual improvement is remarkable 6 by 24. It depends on when the patient present. If patient present earlier, the visual recovery is good, but majority of the patient present late, so the visual outcome is not that much. So mean logMAR visual improved from 1 to 0.5, and there was significant decrease in the CMT SRF height. So surgical intervention significantly improved both anatomical and functional outcome of this pit in the both the groups. So PPV with removal of traction is beneficial in improving the visual outcome of some patients with optic maculopathy, but only in 50 to 60%. Another percentage of cases, the stuffing of scleral tissue or the stuffing of the optic disc pit with the either ILM or with scleral tissue or amniotic membrane maybe cause earlier resolution and improvement in the vision. Thank you.
What would be your approach if the vision is good and the patient is having an optic disc pit? Would you still go for
because in only in one study this spontaneous resolution is there, and 75% where there is a progression of the disease, till NSD is there, patient also doesn't complain. So in one case where 4 years I am following, the maculocytosis is there, but there is no NSD. When NSD start, patient having a subtle metamorphopsia. So that is the time we can take. But the thing is, the long duration progression, this progress very slowly. If we don't operate, ultimately their vision decreases, because we have a patient of optic disc pit with vision finger counting or 6 by 60. With last patient was vision by 6 by 60, 1 year, only 3 month history. I think he's an educated CBI person. So there we have put scleral plug, and there the 100% resolution within a 1 month. Other cases takes time, over 1 month, 2 months, up to a year. But if you plug the pit, then resolution is faster. That's the thing.
My question to the panel was, would you advocate lasers in the early stages? Because there used to be a discussion a while back regarding the laser
I think there was not even now, even earlier, 15 years ago, we were doing laser, light laser burns. Yes, you may think it's not right, but we've done it. Would just keep 2 burn gap apart, not confluent, but would put at least 2 to 3 rows. We did that with sometimes with or without C3R F8 actually. We used to do that, but we realized that most of the patients, the fluid will come back after 2 months, 3 months and 6 months. So each one, as you grow and you will see your techniques you would run. So in my hands or in my clinical understanding, lasers have not worked for me.
Here the 2 ways of pathogenesis, whether fluid is from vitreous or from the CSF. So unless we don't know which patient will respond with what. That is why earlier we used to PPV vitrectomy, but fluid absorption is supposed to be delayed. But this is where we have done 8 case scleral plug in which 2 has been displaced. So there the resolution is very fast. Now the days is people are putting more and more confidence we are getting, putting the ILM or the amniotic membrane plug. So result, this is the within 1 month the fluid has decreased. Thank you.
Sir, in my clinical experience, I have done ILM. I usually will stuff it with ILM because I find it, ILM works fairly easy in my hands.
If you can stuff with confidence, if it doesn't displace next day, you know, initially you may be doing lot of these things where staffing. The prevalence of this disease is very less, so very less cases. Thank you.
That is something that.
Anybody else for presentation? All over.